It's prime time, and I thank the organizers, especially Manu and Niels, for inviting me for this lecture. So it's prime time, and I thank the organizers, especially Manu and Niels, for inviting me for this lecture. So, in cardiac surgery, what do we really know about outcome? That's an important question. First point, we know that long-term survival largely depends on whether or not you're receiving blood or blood products during the procedure. I think so. This is very clear. If you get blood during the procedure, your long-term survival is implicated or impaired. Even more, the more blood you give during the procedure, the less you survive. And the longer the blood is stored before you receive it, the worse. On the other side, to be anemic before the surgery, this is an old slide by Geoffrey Carson, but it's still true. When you have cardiac disease and you are anemic before the surgery, your risk to die is increasing depending how anemic you are. So anemia is not good, and transfusion is not good either. Third point, and it's in annex with the previous speaker, acute kidney injury after cardiac surgery largely depends also on anemia, red blood cell transfusions during the procedure, and the need for re-exploration after the surgery because of bleeding. Another point that already has been mentioned today, that weight gain after cardiac surgery is related to a huge mortality. So it's also a real risk factor for your survival after this kind of surgery. And another point is inflammation. During surgery, cardiac surgery, you are exposed to foreign surfaces in the cardiopulmonary bypass machine. You have a lot of free hemoglobin produced also by the surgery, by the suction of blood in the thorax. You have a lot of inflammation, and it's known since decades that kind of inflammation may increase your risk to die after surgery. So now, coming back to cardiac surgery, you have 4 distinct phases. You have the pre-pump, the pump, the post-pump phase, and the operating theater, and afterwards you go to the intensive care unit. These are very distinct phase episodes, each of them having their own goals and targets and challenges to meet. The targets that are interrelated we have to focus on is transfusion needs and anemia. Both we have to avoid. It's clear that we have to maintain an acid-base status. An acid-base status is related also to transfusion needs, as we know. Then the fluid balance, very important to keep the patient in balance. And inflammation is the 4th target we have to focus on. How do we that do during cardiac surgery? The pump, by the onset of cardiopulmonary bypass, it's a massive fluid load that is exposed to the patient in a few minutes. So that's important. The priming solution and the composition of it might have an important effect on what happens to the patient because it's so massive. Then coming back to outcome, the issue is the type of fluid. Is it the determinant of outcome, direct or indirect? That's the question of today. So you have a lot of possible outcomes, as you see. First point, first target, blood loss. In addition, what the chairman, Dr. Gatt, said today, what's new since last session, it's a very nice consensus text and survey in the Thoracic and Cardiovascular Surgery Journal, and they made a meta-analysis of randomized trials on the use of starches versus albumin on bleeding after cardiopulmonary bypass. What did they find? With the older ones, the very old ones, the more recent ones, that HAS is to be avoided. It's better to use albumin. But what about the new ones, the new generation starches? The results are the following. They compared the new generation starches with the more recent starches. Okay, they saw no difference in mean bleeding, neither in the incidence of reoperation for bleeding after surgery. So their conclusion from the American Society of Thoracic Surgeons is not to use starches during cardiac surgery, not in the pump, and the recent, the newer, the last ones, and the new generation starches, they call it, there is no evidence, as is shown by this meta-analysis, that they are better than the others, and so you can not advise them. Second target, fluid balance. What do you know about fluid balance? There are only a few meta-analyses on fluid balance and on colloidal, on priming in general. When you give a colloid, the fluid balance is more positive, and this is confirmed by a lot of studies. So during cardiac surgery with cardiopulmonary bypass, it's better to use in the priming solution a colloidal solution. We also made a similar approach, and we found that the colloids are in favor concerning fluid balance. Also, for colloid osmotic pressure, it's better to use colloids than crystalloids. So that's an important point. For fluid balance, you need a colloid in the priming solution. And what about acid-base? And acid-base, 20 years ago, we did a study and we could find already that using a balanced solution, and this was a gelatin colloid at that time, compared to albumin and Hartmann, and with a gelatin having no balanced composition, we found that acid-base status was more stable using a balanced colloid. This has been confirmed recently using a starch in a balanced solution. They also found a more stable acid-base profile using a balanced solution. So, a third point, damage to the figured blood elements by the contact with foreign surfaces in the bypass system, contact with air during the suction by the surgeon, contact with the pericardium during the surgery, and also, last but not least, the pumps themselves. This is a nice study done by Simpleman years ago, and they did a trial. They put it on bypass, they put it in fresh blood, and they kept it on a bypass system, coronary bypass, a cardiopulmonary bypass system, and they took for 120 minutes turning the pump, and they used as a priming solution normal saline, HES, albumin, and gelatin. And they found there was less damage, as is evidenced by the free hemoglobin level. That may lead to inflammation. It was less with gelatins and with albumin. It was higher with HIS, AS, and with crystalloids. So, what's the explanation of the difference? Gelatin and albumin are electrically charged molecules, while starches are not, and saline, there's no colloid in it. So that's the hypothesis, that the electrical charge may help to protect the hemoglobin or the red blood cells. This is also evidenced by the meta-analysis on platelets. Platelets are also in favor when you use a charged colloid versus a non-charged colloid. And when you compare with two charged colloids, platelets are maintained. So the figured elements in the blood are better maintained using a charged colloid. And then what about mortality? There's a nice study from about 10 years ago, 12 years ago, in chest, and they compared the long-time survival of cabbage patients, according to which kind of priming solution they received. And you see no difference. Maybe in the long run there could be some difference. There was no difference between the crystalloid, human albumin, and then the HETA starch groups. Maybe they are a little bit less than the others, but there is no difference. So mortality, we also could not show in our meta-analysis years ago that there is a difference according to which kind of priming solution you use during the CPB procedure. So on mortality, nothing can be said. So I have to conclude from this maybe small available evidence to date that the outcome after cardiac surgery is more than priming fluids. There is more than priming fluids between heaven and earth than during cardiac surgery. There's the performance of the surgeon. There is the condition of the patient. There's the hemodynamic stability and other things that count during the surgery. But, in my opinion, you always need to put a colloid in the CPB prime. And I think so, that electrically charged colloids may reduce blood damage and also inflammation. They also may help to engineer a good fluid that is balanced because they are charged. Third point, balanced solutions, and I think so Paul agreed with me, he wrote it, that may abolish the CPB acid-base problem. And then I think so also that minimizing the volume of your circuit may help to minimize inflammation and also damage to the blood and other things. So I want to focus again that for the ideal colloid, you have to mimic the natural one, that's albumin. It should be charged. It's a plea for that. So, and then I come to an end. Thank you for listening.